Good afternoon, everyone. I'm Marcia Connolly, here representing our Association of Lifelong Learners. We're very happy to have Dr. Thomas Thornton with us this afternoon. He will be doing a presentation on screening for colon cancer, our favorite topic. This will be a presentation about the importance of regular screening for colon cancer, when you should have screenings done, how you can prepare, what to expect during the procedure, and what a colonoscopy can tell you and your doctor about your colon health. Dr. Thornton is a general surgeon at MidMichigan Physicians Group. He has advanced training and surgical treatment of conditions and diseases of the esophagus, stomach, colon, and gallbladder, hernia repairs, and he treats diseases involving the skin, breast, and soft tissue. He is also the Vice President of Medical Affairs for MidMichigan Medical Center Alpena. He's been here with us in this area for 6 years. His wife and children live here as well, and they enjoy getting outside on the water when weather permits. He also enjoys scuba diving, running, hunting, and playing hockey. So we're glad he's with us here in Northern Michigan. Thank you, Dr. Thornton.
Thank you. So yeah, I borrowed a presentation from the American College of Gastroenterology. I was going to make a slideshow and then realized they had this very nice presentation that was designed for kind of patient education. So I thought I would use that at least as a starting point, and then certainly answer any questions that there are as we go along or when we're done. So you can go to the next slide. So colorectal cancer is unfortunately very prevalent. It's the third most common cancer in men and women. That being said, it is one of the most preventable types of cancer. For a lot of cancers, there isn't really much to do as far as prevention. You're kind of stuck with dealing with it when it's diagnosed. Colon cancer starts from colon polyps. So if those of you may have had colonoscopies or heard about it, the primary reason we do them is to remove polyps. And not all polyps turn to colon cancer, but all colon cancers start from polyps. So by doing regular screenings and removing the polyps when they're small, you can decrease the risk of getting colon cancer by upwards of 90% or more. Next slide. So this just sort of reinforces what I mentioned. You know, there are no good screening tests for prostate or breast cancer. Colon cancer there is. Now there are things to do, but certainly mammograms can catch breast cancer when it's early, but then again, you're still catching it when it's early cancer. It's very hard to catch it before it's already become a cancer. Next slide. So this kind of goes over what I already mentioned. So basically, by removing the polyps, before they turn to cancer, you can prevent cancer. Again, a lot of polyps, in fact, the large majority of polyps are benign and won't turn to cancer. But there are certain high-risk polyps that, if they're left in place and not removed, those are the ones that go on to turn into cancer, and those are the ones that we're primarily trying to remove when we do colonoscopies. Next slide. So this is kind of a little map of what the colon looks like. Of course, we do a colonoscopy, we go in through the rectum. So that's the bottom of your page there. The colon kind of forms this kind of backwards question mark. So the small intestine is about 15 feet long, and it empties into the colon over on the patient's right side of the body, which is at kind of the left side of your slide. Which is right in the neighborhood of the appendix. So when we do a colonoscopy, we get all the way up through the entire colon. So we start at the bottom and we get all the way up, and how we know we're there is we actually see the opening of the small intestine, we see the opening of the appendix. Even people who've had appendectomies in the past, for appendicitis, you can still see where the appendix was located. So that's how we know that we've got all the way in to make sure we've seen the entire colon. Next slide. Next slide. Yeah, so this is a nice little slide that kind of shows kind of how polyps start. On the left side of your screen is sort of the beginning of the spectrum, and then the right side of the screen is sort of cancer. So There are very rare forms of cancer which are fast growing, but the large majority of colon cancer is very slow growing, which is why if you have a normal colonoscopy, we recommend them every 10 years because it usually takes many, many years for them to develop. So they start as sort of just a little bump, sometimes hard to even see in the colon. And then you'll get to the point where you see basically a little mushroom looking thing. And then as that gets larger, you can start to get what's called dysplasia. So it's sort of a precancerous where the cells are abnormal, but they're not yet cancer. And that's the kind of the preceding step. And then that can go on to become cancer. And on the right side of your slide there, the second to the last picture shows cancer in a polyp. If you get it when it's at that stage, you sometimes can just do a polyp, remove the polyp, and that's all you need to do. Once it's turned into a cancer that's kind of gone through the wall of the colon, then you're looking at a colon surgery. So next slide. So what a polyp is basically it's a clump of cells on the inside of the colon. As I mentioned, not all polyps turn to cancer, but all cancers start as polyps. Polyps, for some reason, some people are more predisposed than others. There definitely is a genetic component. So if other members of your family have had colon polyps, you have a higher chance of having them yourself. And then there are some dietary things. There's not a lot diet-wise that can prevent polyps, but there's some evidence that potentially diets that are heavier in red meats could cause more polyps to form. Excuse me. But that's not universal. So really the only way to know if you have polyps or not is to have a colonoscopy. Next slide. So these are some pictures. These are not my pictures, but I can tell you they're very representative of what we see. So different types of polyps. So the bottom right side picture is kind of what they look at early stages. So sometimes it's very hard to even see. It just looks like a little bit of a lump. And this is why colonoscopy preps are so important. There's been a lot of different changes in the preps over the years, trying to make it easier for the patient, which is good. But when it comes down to it, we basically need to get a good prep with plenty of fluid to wash the colon out, because you can see from that picture on the lower right, if there was any residual material in the colon at all, it'd be very easy to miss that. It'd be unlikely to miss one of the other ones, but it'd be very easy to miss a small polyp. So that's why the prep is so important. Looking at these, I suspect these are probably all benign polyps. The one in the lower left may be an early cancer, but these are the other, at least the two on top, are probably not cancer. They're probably just smaller and larger polyps. But it can often be very difficult to tell in the larger polyps if there's any cancer in there or not. So these are all removed when we do a colonoscopy. Next slide.
This is Doctors Richard Bremer. What's the physical size of those?
So if I were to guess, the one on the upper right is probably about a 5 millimeters, maybe 1 centimeter size polyp. The one on the upper left, it looks like it's zoomed in more, so that might be maybe about a 2 centimeter polyp. And the one on the lower left is probably more like a 3 centimeter area. Yeah, it's about the size. And forgive me, I in medicine, we tend to say things in centimeters rather than inches. So if I convert, the top right is probably about a half inch, then an inch for the top left, and maybe 1.5 inches, 2 inches for the bottom left. Okay.
Thank you.
Next slide. So this is kind of showing how some polyps are hard to find. So on the picture on the right, what you're actually seeing is we've bent the scope back on itself. So you're looking back in the direction you came. In a polyp like that, you could very easily go right past it and never see it. So when we're going in, we're making sure we're kind of looking at the backs of all the folds and things, because the camera's on one side of the scope. So if you have a polyps on the back of on the back of a fold like that, you can imagine you could very easily go past it and never realize it's there. The one on the left, you see there's just a little bit of an irregularity of that fold that's kind of in the light in the front of the camera. So that's an early polyp. Again, if you aren't taking your time and looking carefully, you could very easily miss that too. So some of them are very easy to see, but some of them are very, very subtle. Next slide. Next slide. Actually, go back, sorry. Go back one slide. But I will point out, so on the bottom right picture, you can kind of see this little plastic thing sticking out there with a wire. So that's actually called a snare, and that's how we actually remove the colon polyp. So when we see these polyps, there are different ways to remove them. The most common and the easiest, and the one I utilize almost 100% of the time, is a snare. So basically, it's a wire lasso that we open up the wire lasso, kind of lasso around the polyp, and then you close the wire around it and it tightens, and then we actually apply some electric current, and it cauterizes it as it removes the polyp. So that's actually, that bottom picture is what they're doing, is removing the polyp. So that's a nice picture. Next slide. Next slide. So yeah, as I mentioned earlier in the presentations, this kind of shows, what we're doing. We're going in. So the colonoscope is going in from the bottom, and then we basically steer that up through the colon. The scope is flexible, and then it has some control. So the last 6 inches or so of the scope is movable. So using dials, I can turn the camera left, right, up, down to sort of steer it, and then you actually just advance. You kind of push the scope from down below, and then keeping the camera in the center, and that's how you advance the colon. If you've heard of people who had a colonoscopy that wasn't successful, sometimes this is a picture of what a perfect colon should look like. Everybody's different, so sometimes if you have a lot of redundancy, so the colon may actually be longer and floppy with lots of corners rather than just these predictable corners, and it can be sometimes hard to get the scope through because you're relying on sort of just the friction of the scope pushing through. And if there's a lot of corners, sometimes it doesn't go through well. That's also how you can get into problems if you've heard of people who've had a perforation or a hole in their colon from a colonoscopy. Usually it's because of all these corners that the scope can cause a tear. It's generally not where you're looking with the camera. It's usually, so if you can imagine on this picture, that section of the scope that's got a C-loop, that area causing pressure on the colon is more likely where there's to be an injury. Now, having said that, the rate of injuries in colonoscopies is about 1 in 1,000 or less, and the large majority of injuries don't need to have anything done for them. They're small, so I don't want to scare anybody out of having a colonoscopy because of the risk of injury. But like any surgical procedure, though, there are risks, and that's the one risk with the colonoscopy, is causing an injury. However, the risk of missing a colon cancer is much higher than the risk of an injury, so certainly is worthwhile to do. Next slide. Yeah, so these are some more pictures of polyps. So this is it's all the same polyp, and this is kind of the procedure. So the top right and top left are the picture of the polyp. You can kind of see on the top right, you can see a little bit of a dark staining at the base. So what happened in this case is this polyp is sort of a worrisome appearing polyp. It could be benign, but there could be a cancer in there. And when you're taking out these kinds of polyps, you want to be able to find that area in the future, both with the scope, or if you had to have surgery to remove that section because it's a cancer. Once you remove the polyp, there's no way of knowing from looking at the outside of the colon where it was located. So we do something called tattooing, which is just the same as a tattoo you'd have in your skin, but we inject India ink just under the surface of the colon, and it causes that colon to turn dark. So you can see in the bottom left picture, the polyp has been removed with the snare, and you're seeing that dark colored ink. That will stay there permanently. It won't cause any problems. Nobody will know it's there. But if we have to go back in either with the colonoscope or if we have to do a surgery, you'll actually see that ink on the outside of the colon as well, so we can identify the area. And on the bottom right, the colon, that polyp is actually laying free in there. So it's been removed and then it'll be retrieved. There's different ways we can do that to get it out of the scope. The small polyps can actually be sucked up with the suction on the scope. This one is going to be too large for that. So we have different nets and things we can grab it with to bring it out with. So next slide.
Or because a lot of times you do the stool test, and I mean, that personally, that's how they decided I should have because there was a little bit of blood in my stool test, and then I had just the beginning of a follow-up.
I think I missed the first part of the question. I think, do you have a question?
I bleeding, if there's any bleeding associated with the polyp, and the stool test is something that some doctors have you do, and prior to age 50 or something like that, just to see if there's any bleeding in your.
Yeah. So the stool test for bleeding is a good test. Certainly, the disadvantage is that you can't do anything if it's positive other than have a colonoscopy. Some polyps, if they're large, will bleed. The other limitation with those types of tests are that a lot of polyps don't bleed. They're a smooth surface and they won't bleed, so the stool test won't be positive for those. But certainly, if you're not going to get a scope, or for some other reason, the stool test is better than doing nothing at all, and certainly can lead to the need to do a colonoscopy. But not all polyps will make that be positive. Okay, next slide. All right, next slide. All right, so these are some kind of statistics in the US of colon cancer. So men and women have pretty similar risks. Men have a slightly higher risk, but you're talking only 1 in 23 versus 1 in 25. So the risk is very similar between the two groups. Interestingly, we're seeing a higher incidence of colon polyps in younger patients and colon cancer. The recommendation used to be to have colonoscopy starting at age 50. In the past few years, that has changed. Actually, the American College of Surgeons back in 2014 had recommended that they start at age 45. However, most of the insurance companies, or essentially all of the insurance companies, wouldn't pay for a screening colonoscopy at that age. Now, this past year, the American Preventive Services Task Force actually changed the recommendation to age 45. And now insurance companies are getting behind that. And the reason being is that we're, for some reason, seeing more colon cancer in younger patients. I've seen that anecdotally here in Alpena. I can recall in the past 2 years, a half a dozen patients under age 40, a couple under age 30 who were found to have colon cancer. Now, they obviously weren't getting screening colonoscopies. They came with blood in their stool or some other cause. And we don't exactly know what's happening. Some of it is likely diet and lifestyle. Americans, especially compared to other countries, unfortunately, we're becoming more overweight, we're becoming more sedentary. So those probably are contributing. But there also is a higher incidence of seeing genetically associated colon cancers as well. Next slide. So some risk factors that put individuals at increased risk: anybody who's had a family history of colorectal cancer. When we say family history, what we're really talking about is first degree relatives. So that would be parents, siblings, and children. If you have a grandparent with colon cancer, theoretically, you could have a slightly increased risk, but it's probably not very significant if your parents don't have colon cancer. If your parents have colon cancer, if you have a sibling with colon cancer, or if you have children with colon cancer, that significantly increases your risk. With family history of adenomas, which are polyps, that increases your risk. Cigarette smoking increases your risk of most cancers, colon cancer included. Obesity can increase risk. Gallbladder removal. So interestingly, this is on this list. I've never heard of that before, but it must have some connection, but that's not one that I had ever heard of. Physical inactivity, like I mentioned, the sedentary lifestyle, previous radiation. The classic example in men is men who've had prostate cancer sometimes have radiation to their prostate for the prostate cancer. The prostate is directly behind the colon, or the rectum specifically. So that gets radiated inadvertently in treating the prostate cancer, and that can cause problems. It can cause bleeding just because of damage to the rectum, or it can actually cause cancer. There are some familial disorders that women who've had cancer in their uterus or ovaries. There are some cancers that are also linked to colon cancer. So depending on the type of cancer and the genetic makeup of that cancer for a uterine or ovarian cancer, that can actually increase the risk of colon cancer. Ulcerative colitis or Crohn's colitis, those fall into the category of what's called inflammatory bowel disease. It essentially is a chronic inflammation of the colon or the small intestine. These patients, because of the chronic inflammation, are at significantly increased risk of colon cancer, to the extent that they usually have colonoscopies every 1 to 3 years because the risk is so high. And there also is a proclivity to colon cancer in African Americans versus white Americans. With the family history of colorectal cancer, I mentioned earlier the recommendation is to get colonoscopies every 10 years if the colonoscopy is normal and if you have no family history. If you have a first-degree relative with colon cancer, so again, parent, child, or sibling, then it's recommended you have them every 5 years, and you sometimes start them earlier. So the recommendation is to start the colonoscopies 10 years before the relative was diagnosed. So if you had a parent who was diagnosed at age 50, then the children should have their scope starting at age 40. If you have a sibling starting at, diagnosed at age 40, then everybody else should be at age 30, ideally. So next slide. Next slide.
Question.
Yes.
Okay. Will you expound on how gallbladder removal comes into play? That's recently been diagnosed for me as of last week in Ann Arbor with Dr. Risk, that my gallbladder surgery is what is causing all my problems. I'm losing blood and it's showing up in my stool occasionally, but I'm taking iron every day and they can't find out where. And then the other alternative was to catch the colon on the in-between, between the stomach and the colon with a camera issue. Could you kind of fill that in for me and maybe make it more clear?
Yeah, so to be honest, until I saw this slideshow, I had never heard of gallbladder removal being associated with colon cancer. So I can't say much on that because in all my training and years, I've never heard of that before. Now, gallbladder removal can cause other things. So it's fairly common after gallbladder removal to have loose stools long-term. What the gallbladder does essentially is it stores bile. Bile is a digestive enzyme made in the liver, which breaks down fat. So when you eat a fatty meal, if you have a gallbladder, your gallbladder contracts and kind of gives you a bigger shot of bile to digest the fat. When you don't have a gallbladder anymore after surgery, you don't have that big shot of bile. So fatty foods tend to run through you quicker and generally cause some looser stools, which is common. But as far as causing bleeding, I would, again, I can't say for sure, but I would suspect it's likely not related to the gallbladder causing the bleeding, but there are a lot of different causes of bleeding, either the stomach, the small intestine, or the colon. As you kind of mentioned, it's easy to evaluate the upper and lower ends of the digestive tract. We can run a camera in through the mouth and look in the stomach in the first part of the small intestine. We can reach about a foot down into the small intestine, and then we can do the colonoscopy. And actually, with the colonoscopy, we can get into the last few feet of the small intestine from the other end, but there's about 10 to 12 feet in the middle that we can't reach. And that's where that swallow to camera study comes into place. That's not perfect because the camera is going through in a capsule. You have no way of controlling it. So if it happens to be pointing away from the area as it goes through, you could miss something, but it's really the only thing we have to evaluate the middle. Now, that being said, it's exceedingly uncommon to have something in the center, in the small intestine in between. There are a few rare small intestinal issues, but most issues, I guess if you want to say for luck, because we can see them, happen on either end that we can reach with the camera. So certainly, in the setting you're describing, doing potentially, upper endoscopy and a colonoscopy is probably indicated to look for source of blood loss. But I would suspect it's probably not related to the loss of your gallbladder.
His method of dealing with it is high fiber intake, and see if that resolves the problem. And then if that doesn't resolve it, we'll go to the camera on the in-between and maybe a CAT scan.
Yeah.
that's one of the reasons why I wanted to make sure I got here. I wanted to hear what you had to say about that, but you answered my question. It's the liver bile that is triggering it. That's what's triggering everything, and maybe that's what's causing some of the blood loss as well. Thank you.
Mhm. Okay, next slide. So what are the signs and symptoms of colorectal cancer? Well, unfortunately, there usually isn't any. So like we mentioned, all colon cancer starts in a polyp, and then unfortunately, there's varying degrees of how big the polyp can get before it turns into a cancer. Some of the more aggressive ones, it can be a pretty small polyp that turns into a cancer early. Some of them can grow to a very, very large polyp before they turn to a cancer. Really, the only time that colorectal cancer causes symptoms is when it gets advanced. So if it gets large enough to cause an obstruction, then people would come in with essentially a bowel obstruction, or if it bleeds, which also is usually when it gets larger. When I say bleed, I mean actually seeing blood in your stool. The stool tests are testing for microscopic blood, which can be from polyps or cancer, but some of the larger cancers can actually, frankly, bleed and have blood in the stool. But to be honest, those symptoms usually, when those occur, the cancer is usually advanced, and it's not uncommon when it gets to that stage to already be in lymph nodes or to be spread elsewhere. The early colorectal cancers that are easily removable and cured generally are found on a screening exam and haven't caused any symptoms. Now, blood in the stool is very common, and most causes of blood in the stool are not cancer. So, the number one cause of blood in the stool is hemorrhoids. Even if you don't have, so most people think of hemorrhoids, they think of, the big itchy burning hemorrhoids on the opening of the rectum, and those are usually not subtle. But the hemorrhoids that often bleed are called internal hemorrhoids, and you would have no way of knowing you have them because they're actually located up inside the opening. So those can actually bleed and not cause pain or anything. That's probably the number one cause of bleeding. If we get young patients with bleeding like that, we can do an exam in the office, even with a little a plastic scope that just looks inside about an inch or two. And if we see those hemorrhoids, we can treat those and treat bleeding. As you start to get older, when I say older, I said anybody over 40 that comes in with rectal bleeding, we're going to recommend a colonoscopy, even if we think it's hemorrhoids, because you never want to assume it's hemorrhoids and have it be something else. Other things that can cause bleeding, diverticulosis is kind of these little outpoachings of the colon. That's very, very common in our country. It's also related to not enough fiber and bad diet. Diverticulosis in and of itself is not dangerous necessarily, but it can cause bleeding. And that's probably the one of the top causes of rectal bleeding or blood in the stool. But so when somebody has bleeding and I see them in the office, I always reassure them that, more than likely it's not cancer. But we always have to check for cancer to make sure, because you never want to miss that case. Next slide. Yeah, so should I wait till I get symptoms? Like I said, no. If you wait till you have symptoms, you've already kind of missed the boat, and there's a good chance that it could be advanced. So, the symptoms that you can have: blood in the stool, change in bowel habits, change in the shape of your stool, pain, abdominal pain, weight loss, anemia. Those can all be caused by other things besides cancer, but they can be caused by cancer. And oftentimes when you have one of those symptoms, it can be more advanced. So the best way to prevent that from happening is to get regular screening colonoscopies to keep this from ever happening in the first place. Next slide. All right, so get screened. So the definition of a screening colonoscopy is a colonoscopy in somebody who's not having any symptoms. So about 80% of the colonoscopies that I do are in people who are there just because it's time to get it done. They're 45 or 50 and getting their first one, or they had one 10 years ago, or they have family history and they had one 5 years ago, or they had polyps in the past themselves and they're due for repeat. Those are the ones that we do most. And that's the best way to do it, because if you're staying on target and getting screened when you're supposed to, it is very rare to ever develop a colon cancer. There still are cases where somebody has a very advanced cancer that grows between screenings, but those people are the rare minority rather. And people that get on top of their screening and get screened periodically generally will never get a colon cancer. Next slide. Next slide. Yeah, so there are a couple different options for colorectal cancer screening. The gold standard option that is recommended by all medical professionals is a colonoscopy. That being said, there are limitations, and there are some people that, for some reason, either personal, emotional, there could be medical reasons that a colonoscopy is not an option or not the best option. So there are other tests to get this done, and that was alluded to by a question earlier. So there are kind of the classic is the fecal occult blood test, which basically is the little stool card that you smear, and it's looking for microscopic blood. That was kind of the original test, has been around for 30, 40 years, and that is a reasonable test in somebody who's not getting colonoscopies. Now, it doesn't replace colonoscopy, and it's not as good as colonoscopy, but as it says in the last sentence here, the best screening is the one that gets done. So if somebody is not going to have a colonoscopy for whatever reason, if you can do a screening test, one of the stool tests, it's better than nothing. More recently, there are some fancier tests that look for changes in DNA of the colon that can indicate potentially a polyp growth. These more are looking for dysplasia. So in order for one of those tests to be positive, usually the polyp has to be pretty advanced. The small polyps generally aren't going to cause anything to be positive, so you're going to miss those. But you would catch a bigger polyp, or you should catch a cancer. Again, it's not 100%, but it is fairly accurate. The one thing to remember about those tests are they have a pretty good positive rate, but they're by design they're overly positive. So there's a high false positive rate. The last thing they want to do is miss something. So there's a lot of patients who get sent for colonoscopy after one of those tests was positive, and we don't find anything because the false positive rate is high. But in a test like that, you'd much rather have that than to have a false negative rate where somebody has a cancer that's missed. So the large majority of people who have a positive, either a fecal occult blood test, or you might hear Cologuard or FIT or different brands, the large majority of those that I do colonoscopies on, we don't find anything. They were false negative, or false positive rather, I'm sorry, which is a good thing that we don't find anything. But that's always the first thing I tell patients when they come to see me. Usually they're pretty upset about this positive test. And I always tell them, you're in the right spot. We need to be doing this now, but we're likely not to find anything worrisome. Next slide. Yeah, so the one-step screen test, the gold standard is colonoscopy. So we've been talking about that all along. So you do basically run a camera up through the colon, visually inspect the colon, and then we can take biopsies or remove polyps and essentially treat it while we're there. So that is the most sensitive. By looking directly, we're much less likely to miss anything. And we can often remove the polyps when we're there at the time of the colonoscopy, and then the patient would need nothing further done. Now, you can miss things. There is, depending on the literature you read, like a 10 to 15% polyp miss rate by doing colonoscopies. Now that's those really small polyps. We're not missing 10% of the large polyps, but some of the really small ones, if they're hidden in a fold or behind a fold, or the prep isn't great, some of those can be missed. So there is about a 10% miss rate with some of the small polyps, even in the best person's hands doing it. But because colon cancer is so slow growing, even if you miss a very small polyp, as long as the patient stays up to date with their continuing colonoscopies, the next time you do it, theoretically that polyp would be larger, and then you're unlikely to miss it. So it's not a perfect test, but it's the best test we have, and it's very good. Next slide. Yeah, so then the other, as I mentioned, there's different stool tests. So the FIT test is a brand name. Fecal immunochemical tests looks for microscopic blood, similar to a fecal occult blood test of the old way of doing it, but it's a more accurate And then the Cologuard is actually looking for the abnormal DNA associated with colon cancer. So those are the kind of the two most common tests you'll hear that are somebody who doesn't want to have a colonoscopy, can't have a colonoscopy. That's the best option otherwise, but again, does not take the place of a colonoscopy. It is not as good as a colonoscopy. Next slide. All right, next slide. So the recommendation, and these just changed again. Well, I should say the American College of Gastroenterology, and then my college. I'm actually part of the American College of Surgery, because in the U.S. colonoscopies are done by both gastroenterologists and by general surgeons. So it depends on what area you are. We both do them. We're both trained to do them. The difference is gastroenterologists don't do surgery. So if they find a colon cancer, then they end up referring to a surgeon to treat it. But both of us specialties do colonoscopies. And both of our groups recommended about 5 or 6 years ago to start doing it at age 45. As I mentioned, the insurance companies didn't agree, didn't want to pay for it. So it kind of stayed at age 50. But as of this year, the Preventive Services Task Force for the US has recommended 45 as well. So now the insurance companies are coming in line to support starting at age 45. They recommend screening from age 45 to 75 for sure. And after that, it's recommended to be personalized. What I always tell patients is I don't have a set date that I stop screening. It has to do with the patient. I've taken care of plenty of 90-year-olds who are healthier than my 60-year-old father. And I've taken care of some 70-year-olds who looked like 90-year-olds. So it has to be personalized, to the patient, what other health problems they have, what's their health like overall, will they tolerate going through a colonoscopy, and also what their care wishes are. Everybody's different as far as how aggressive they want to be with their care. And it may be that you have a 75-year-old, or I'll say you may have an 80-year-old who just has a mindset of, at this point, I've had a good life. I'm not going to be really aggressive with my care. If I get cancer, I get cancer. I don't want to deal with it. And if that's the case, that's not somebody we would do a screening on. But if we have the same 80-year-old who is very healthy, lives independently, is enjoying life, doing activities, and expected to have another 10 or 20 years of life, then it might make sense to do a screening on that person. So it is very much personalized, once you get to about age 75. But we certainly don't say when you hit 75, you shouldn't get a colonoscopy anymore. That's not the case. Okay, next slide. So African Americans, as I mentioned, do have a higher risk of colon cancer. It's not substantially higher, but it is higher. But the recommendation is essentially the same of starting at age 45. So that part isn't any different. And it's the same intervals. It's the same 10-year interval if it's normal as well. Next slide. All right, so this is just reinforcing that we recommend starting at age 45 with our screenings. Next slide. All right. So screening for patients with family history of colorectal cancer or polyps. So as I mentioned earlier, if somebody in your family has colon cancer, and like I said, we're really looking at first degree relatives. So if you have a parent with colon cancer, a sibling, a child, then your screening will be different than somebody who doesn't. So like I mentioned, it's usually every 5 years with the family history, not every 10. And then we often start them earlier depending on what age that person was when they're diagnosed. If there's any question at all of whether you should start earlier because of your family history, ask your healthcare provider. The family practice doctors, the primary care providers are knowledgeable about this as well. So if you're in doubt at all, ask your primary doctor, if you should be screened earlier or more frequently, and they'll be able to tell you. If they don't, they certainly will reach out and ask us. So, and genetic testing is sometimes required. This really only applies to people who have a colon cancer or who had a a family member with colon cancer. And if there's certain criteria that have to be met, a young age colon cancer, a colon cancer with other cancers associated in that person or the family, or there may be specific markers in that particular colon cancer we see on pathology that would suggest that. And in those cases, we may recommend genetic testing, which could affect that person and potentially their children. But genetic testing is not recommended routinely on everybody. It's tailored to those who have been affected or have family members who've been affected. Next slide. Yeah, so how to arrange your colorectal screening. Most time, if you have a primary care provider, they're usually going to be on you about this. They keep track of the different screenings, and if you haven't had a colonoscopy, they're likely going to talk to you about it. If they don't, and you haven't had a colonoscopy, talk to them about it. You also can call our office directly. If you call the MidMichigan General Surgery in Alpena, we don't require referrals for screening colonoscopy. So if you think you need to get one done, you can call our office and do it that way. But you can also go through your primary care provider as well. Next slide. All right, I think that's essentially all that was in this. At this point, I guess I would entertain questions that you have.
Any questions here in the audience?
I'm wondering about the preps. There are a number of types of preps that people are suggested to use. I know that's often the part of the preparation for doing the testing that's most concerning to people. Do you have one you suggest most often, or is that also something you match to the individual?
Glad you brought that up. Yeah, I was actually going to tell you about how it goes if you get a colonoscopy. So, yeah, 100% you're correct. The prep is sort of the most unpleasant part of the procedure. So if you get a colonoscopy, you do the prep the day beforehand. Preps have come along. 15 years ago, there was really only one prep. It was go lightly, which is the big jug, or go heavily was sort of the joke that was made about that. It was 1 gallon of a electrolyte solution with laxative. You drink the entire gallon, usually as quick as you could, and that would get you cleaned out. I don't use that prep. I've never used that prep, actually. The prep that I use, and actually that all of my partners in Alpena use, and actually the prep that's recommended by all the major organizations, is a Gatorade-based prep, actually. So we mix Gatorade or any kind of electrolyte sports drink with Miralax. So Miralax, you may know, is a powder laxative that you get for constipation. Well, essentially, we mix the entire bottle of Miralax with 64 ounces of Gatorade, so half a gallon, to be taken the day before the procedure. My prep has actually changed about 3 years ago. It's now a split dose. So the patient takes half of the prep the night before, or the late afternoon before, and half of the prep very early in the morning of. The reason being is, well, 2 reasons. One is, by taking the half a volume at a time, it's usually better tolerated, because trying to get 64 ounces of the prep down quickly is often difficult and causes nausea and sickness. So by splitting it up into 2 doses, it makes it easier to take. The other reason we do it that way is we've had a lot of evidence that suggests that doing a split prep with a lot of the volume the morning of gives a better prep. Because even if you haven't been eating, your bowel is still secreting mucus. You still have bile from the liver and digestive enzymes being released. So if you have no prep after, the evening before, especially if you're not the first scope in the morning, those bowel secretions can make it hard to see and can stick to the walls of the colon, and it can make you miss something. So by taking that early morning dose, it kind of gives one final flush and gives much better visualization, a better view for the surgeon or proceduralist doing the colonoscopy. So the nice thing about the prep with being the Gatorade and Miralax doesn't have a taste. So it just tastes like you're drinking Gatorade. So for patients, it's much better tolerated. It doesn't taste bad. It tastes like Gatorade, whatever flavor you get. It's still, a fairly high volume. It's 32 ounces twice. You're still going to spend the evening in the restroom because it still has to flush you out, but it's easier to get down. People have asked about, isn't there just a pill I can take? And the answer to that is no. And the reason being is that the liquid volume is what's doing the work, because we actually have to essentially, power wash the inside of the colon to be able to see. So if we don't have that liquid volume, there's no pill that you can take that, it may clear out the fecal material of your colon, but you're still going to have a lot of residue if you don't wash it out of there. So unfortunately, that liquid volume is never going to get down to zero, because we've decreased it from a gallon to a half gallon, but it's probably not going to go much lower because we actually require that mechanical washing. The colonoscopy procedure itself, so the day before, the patient is on a clear, so let's say that your colonoscopy was on Friday. So on Wednesday would be the last day that you could have solid food. All day on Thursday, you'd be drinking liquids. You'd start the prep in the afternoon on Thursday, but you could have liquids all day with the prep. And then after, depending on what time your procedure was on that Friday, you'd have to have nothing to eat or drink for about 3 hours prior to the procedure. So depending on what time your arrival time is, the time you can stop drinking is variable. Come into the operative area, come to pre-op, the nurses get you changed, put an IV in. Really, the IV is the most painful part of your day. So once the IV is in, we give medication through the IV that puts you to sleep. It's called propofol. You may have heard of it from the press. That was, the quote unquote Michael Jackson drug. He was using it to sleep. Unfortunately, he was using it, nobody was monitoring him. So it puts people in a very deep sleep. It can slow down breathing. If you have an anesthesiologist who's giving it to you and watching you, it's very, very safe. If you have somebody who gives it to you and turns it on and walks away for the night, not so safe, as Michael found out. So, but we use that medication. The benefit of it is it's very fast acting. It kicks in about 3 minutes or less, and it wears off in the same amount of time. So we shut it off when we're finishing the procedure, and most patients are wide awake within about 10 or 15 minutes with no hangover effect. You don't feel drowsy the rest of the day. So it's a very good drug. And it's unlike colonoscopies of 10, 15 years ago, which were done with different drugs. People sometimes watched on the screen or were sort of in this twilight, sort of awake. With the propofol, patients are completely asleep. So generally they don't remember ever having gone to the room, or don't remember us ever starting the procedure, because they're in a deep sleep. So the procedure itself is very well tolerated. It's not painful. People wake up and usually say it's the best sleep they ever had. So, so that's kind of the procedure in a nutshell.
Could I ask a question?
Yes.
Have you seen any connection between cancers, for instance, lung cancer and colon cancer?
Lung and colon is not, there may be some rare condition, but lung and colon aren't generally related. There are some colon and pancreas that are related. There are some colon and female cancers that were alluded to earlier, some ovarian and uterine cancers. So there are a few of these basically genetic diseases that if you have that disease, you have a higher chance of certain cancers. Lung cancer, the largest cause of lung cancer is smoking. But then there are other environmental things. Radon can cause it, or you can just get it sporadically for no reason. But is what I'm thinking. Like I said, there may be a rare disease condition I'm not thinking of, but I don't think of any direct connection between lung and colon. But there are between colon and a lot of other cancers.
Thank you.
Any
Thank
other
you.
questions from online? Any questions from in the room? Dr. Thornton, would you like to wrap up anything?
No, I would say that if you have any further questions about colon cancer screening, talk to your doctors. If you haven't had it, have it done, I strongly encourage you to consider it. Again, colon cancer is one of these, strange cancers that it affects a lot of people, but it is very preventable. So if everybody had their colonoscopies when they're due, we'd see a lot less of it. Unfortunately, we see a fair amount of colon cancer in Northeast Michigan. Our office is happy to take care of anybody. We have 4 partners here in Alpena who do all of our procedures here in Alpena, so you don't have to leave the community. There are, with our hospital here, we're in a smaller town, so we're somewhat limited in some of the specialties we have. But from general surgery, and specifically for colon cancer, we generally can take care of those patients without ever leaving town. So colonoscopies are done here. If worst case scenario, if somebody does have a colon cancer, we can almost always treat those here without having to leave town. The 4 surgeons we have here are all trained in colon cancer surgery in our training. And if you have the surgery here, you have the surgery elsewhere, you're going to be getting the same surgery. Not everything's that way. Depending on if you need cancer for if you need surgery for a lung cancer or a pancreatic cancer, those aren't things that we can do in Alpena, unfortunately. But colon cancer is one of the things that we can do here. So we can keep people in the community. So if you have any questions at all, reach out to your family doctors. Give our surgery office a call. Our staff are excellent. They can answer questions and get you scheduled if you need it. Just get screened.
Anyone else? Questions? Great. Thank you, Dr. Thornton, for a very informative presentation. I think I learned a lot. So with that, we'll end the program. Thank you very much.
Thank you for having me.